Before I even ask questions about the product itself, the service, I'm curious if there's a backstory as to why you started Medically Home.
Oh yeah. So I'm an engineer by training, and I have background in healthcare services. And about 12 years ago, I was joining the board of an academic medical center. And as a coincidence, my dad was admitted into that hospital while I was going through that process. So I thought it would be helpful if I kept a diary of his care, and then I could share that with the interview process. And unfortunately, while I was watching, my dad passed away from 3 consecutive medical errors, which is how Medically Home was born. About a week after his funeral, I got a chance to look at the P&L of the hospital. And it was the first time that I actually knew or recognized that about 65 to 68% of the cost of a medical episode in the hospital is bricks and mortar overhead, which only leaves about 32% of the cost of care to actually deliver medical care. When I recognized that through my background and experience, I realized it was inadequate. The business model of a hospital does not allow for enough medical care for a patient to safely recover from medical illness in an appropriate amount of time. Because the payments are fixed, the patient's journey through the medical system in a hospital is typically rushed, a lot of handoffs. And because of my background in factories, I recognized, the change of hands, the constant transfers, and the way in which patients were becoming part of an industrial process. And the thought struck me that if there's that much capital being deployed to support a patient's medical episode using bricks and mortar overhead, what if we took that bricks and mortar overhead and we arbitraged it out of the way we deliver care and spent that money instead on much more care over a much longer period of time in a site that's much preferred by patients, which obviously is their home. So I did a lot of research. For the first year, I had been collaborating with Johns Hopkins Medicine in my previous business and discovered Dr. Bruce Leff's work in the area of recovering from acute illness in a home setting. And the data was pretty stunning over many, many years, over many randomized controlled trials around the world, and it demonstrated that patients felt safer at home, they preferred to recover from illness at home, they slept better, less falls, 16% reduction in mortality, less infection, and overall just a much better chance of recovery. So with that, combined with the financial information, I set out to build a virtual hospital. It was never about telemedicine, and by the way, it still isn't, although we are in the telemedicine category. It was about trying to figure out all of those really complex and extraordinary number of services a patient receives in a hospital. How could you possibly do all of that away from the hospital? Because telemedicine is a very small portion of that. If you need an x-ray, you can't telemedicine an x-ray, you can't telemedicine an infusion nurse, and you can't telemedicine a medical procedure at bedside. So the idea was to take every single discharge from the hospital, study it, and actually go one by one, what's actually happening at bedside in the hospital? Oops, I'm sorry. What's happening at bedside in the hospital, and what, if anything, could we do to take that centralized care delivery and decentralize it? Now remember, at that time, early days, Amazon was really coming up, and people were starting to get accustomed to things that used to cause them to go in their car and drive to get something. It's now coming to them. So there was a consciousness change when this all began around, well, maybe it could be brought to me instead of me having to go to it. So we iterated and iterated, and we discovered very quickly most of the things in the idea were not very difficult, but one was very, very difficult. And that was actually getting the services reliably to the patient at bedside rapidly. So we divided all of, this is about 11 years ago now, all of the services that go to bedside into a number of categories. One was, is the patient, how acute is the patient? In a hospital setting, there are typically 4 levels of acuity called severity of illness. It goes 1 through 4, 4 being the ICU, 1 being the lowest level of medical acuity a patient would be normally hospitalized and admitted to the hospital for care. So we focused on each one of those, 1, 2, 3, 4. What services was the patient getting, and what, if anything, could we do to bring that to the patient to their home? And we decided to focus on level 3. Level 4 we knew would never happen. ICU level patient is just in much too fragile a condition. And level 1, that was already being done by hospital home programs around the world. particularly in Australia and Western Europe. We were most interested in 3 because nobody was doing 3. And the vast majority of hospitalizations are not 1s or 4s, they're actually 3s and 2s. So we got into it and discovered that we would need to probably do 4 things to enable this idea. First was we would need a medical command center staffed by physicians, nurses, nurse practitioners that operates 24 hours a day, 7 days a week. And in a hospital, there are nurses, nurse practitioners, and doctors around the clock. In the home, there isn't. So we need to create a surrogate for that, which meant the command center, always available. But most important in our learning, it wasn't just available to the patient. It was available to the patient's family. Because as we got into this, more and more we discovered, particularly with older patients, it's the patient's family that runs to the hospital. It's the patient's family that calls 911. It's the patient's family that's freaking out when dad or mom or my husband isn't breathing or being responsive. So the idea was to create this command center, make it available inbound for both the patient and the family around the clock, and outbound based on protocol. How would we care for this patient? How often would we interact with them? So that's the command center. We could centralize it. It could scale very easily because we could care for patients in Hawaii, in Puerto Rico, in California, in Oregon, et cetera. And that idea, other than cross-licensing physicians and other clinicians, it was a very scalable idea. And I had some experience, ran a very large call center in my past. Second, we needed technology in the home that allowed us to have access to the patient's status, their vitals, access to them visually, obviously have audio access back and forth, again, the patient and the family. We needed emergency power backup because in a hospital you have that. We needed backup cell signals because if we were going to connect with the patient through the internet, we needed to make sure we never lose connectivity. We needed an emergency response system in case something went wrong, and we needed a whole host of other supplies and medical equipment to turn that home into a temporary hospital unit. Let's call that the tech stack plus the temporary hospital unit. And that was the second thing. That was easy to get our brains wrapped around. So was the command center. The third one, not so easy. The third one was there are 18 services, Kyle, that go into the patient at bedside in the hospital. And they're either clinical services like an infusion nurse or a nurse performing a procedure, or they're goods like antibiotics. And whether the patient's getting services or goods, most of the time they're clinical services and goods. Sometimes they're non-clinical services and goods, like a meal at bedside is a non-clinical service and a good. So we studied every one of them and discovered there was a very large amount of those services already available in the community. However, they were available for something called a post-acute care world. They were available for patients who already were discharged from the hospital. Because those companies operate on such a very, very tight margin, they don't have excess capacity. They don't have people waiting around to rapidly dispatch to the patient's home. In a tight margin business, you have to literally operate your staffing very, very tight. So if I needed to send a nurse in the next hour or a paramedic in the next 20 minutes to a patient's bedside, there's no excess capacity in the post-acute services in the community world. So we had to rethink, how do we take these services, these capable people and talent, and turn them into an acute supply chain? In effect, elevate them, amplify them, accelerate them, and change the level of reliability, because as you move up in patient acuity, the risk to the patient goes higher and higher if you have less and less response time. Does that make sense? So we had to basically put together a way to restructure the entire supply chain that already exists in the community that would ultimately have to be turned into an acute supply chain. And that was 11 years ago. That focus over the last 11 years has differentiated us from anyone in healthcare, anyone in telemedicine, anyone in hospital care at home, because that's the it. Everything else, to get to a patient, to send a physician to a house call, to have a physician do a telemedical visit, not hard to imagine anymore. What's very, very difficult is that physician orders 9 things. He orders oxygen, an antibiotic, an x-ray. He orders a Foley catheter. He orders all those things. And he has to know, or she has to know absolutely for sure it's going to get there and in time. Because if he or she doesn't, he or she is going to say that patient belongs in the hospital. Much too risky. So the supply chain, Kyle, was the big idea, but the most challenging part of the idea. So that was the third leg of the stool. The first was the command center, the second was the tech in the home, and the third was the supply chain. The fourth was as challenging as the third, but we could imagine how we would do it. The fourth was, how do you take these hospitals? We didn't want to compete with hospitals. We wanted to support them, help them make the transition to this new world that we saw coming. So our idea was, how do you take this platform and integrate it with Epic or whatever EHR system they have? Let's say it's Cerner or ClinicalWorks, because they just made a gigantic investment to automate their electronic medical records. And if we walk in with a parallel system and they have to go use both systems, that was not going to fly. So independent of everything, we knew whatever we built would have to seamlessly integrate with the existing host electronic medical records. So that was the big effort. And the last was to take software and actually purpose build all of the things I told you, including the ability to track, where's the oxygen right now? When is it coming? Who's the oxygen therapist? What's her background? All of the things that basically operate a virtual hospital has never been built before. Epic doesn't have it. No one has it because no one's ever operated a decentralized hospital before. So we had to build all of that from scratch. And we had to have it integrate with Epic. So those are the four big things we had to build, and it took a long time. This is independent of getting regulatory approval, reimbursement, any kind of investor. This is all self-funded by myself and my two partners. So we went through that process, and eventually, 4 years ago, we launched in Boston with Atrius Health, Harvard Vanguard, and had some success, and then the pandemic. The pandemic drove everything that's happening. I would say the momentum of it is the pandemic, and it's not the COVID part of the pandemic. It's a change of consciousness about whether hospitals are even safe anymore, whether they have the capacity to flex up and down based on demand, and most importantly, whether their business model is friendly to patients as they've now experienced telemedicine, and then wondering, in some cases worrying, do we have the right business model going forward? So that's the long-winded history of Medically Home. It started with my dad. It went on a journey, mostly an engineering journey, a research journey. Along the way, we did a clinical trial and published it to prove that the model was safe. Along the way, we took many, many partners that are now, I'm happy to say, part of our ecosystem. So that's the history of Medically Home.